Welcome everyone to today's Health Education and Learning Program webinar, or HELP webinar. This is being hosted by the RIP team from the National Rural Health Resource Center. And for those of you that are not participating in RIPT or haven't in the past, RIPT stands for Rural Healthcare Provider Transition Project. We also have attendees on today from our Rural Hospital Stabilization Program and our Delta Project, which is the Delta Region Community Health Systems Development Project. And we're really happy to have you all here. Today's topic is a great one. It's winning the denials management battle, best practices for prevention and resolution. I'm Molly Carmack. I'm the program coordinator from the RIP team, and just a few housekeeping details. Your audio was most likely muted by default when you entered the room, but when it gets to questions later on, please come off mute, put questions, comments in the chat. We love to see those. And as you can see, we're recording, and we'll send that out with a copy of the slides. So a little bit of background on RIPT, for those of you who are not familiar. RIPT is a project supported by HRSA and the Federal Office of Rural Health Policy. Janine Myers is our project officer. And just for your reference, we have our funding statement and disclaimer here as well. Then the purpose of RIPT, we're designed to help strengthen organizational foundation and the key elements of value-based care, including but not limited to efficiency, quality, patient experience, and safety of care. And the goal of RIPT is to guide small rural hospitals and certified rural health clinics that are not participating in value-based care through advanced alternative payment models to prepare for and position their organizations to be effective participants in a health system focused on value. And now I'd like to welcome today's speaker. We have Amy Graham from Stroudwater Associates. We've had Amy speak in the past, and we're really happy to have you back. You drew a big crowd this time, too. Amy is an experienced healthcare executive with over 20 years experience, providing vision and direction in finance and revenue cycle. She serves rural healthcare providers in hospitals, clinics, labs, and pharmacies. Her professional expertise includes understanding the synchronization of revenue cycle management with financial statements, month-end accounting consolidations, strategic analysis and development, and direction of budgeting and forecasting activities. Amy's insights into revenue cycle issues are valued and very sought after across the industry. So thank you for being here again today. I am going to stop sharing and hand things off to you, Amy.
Thank you so much. And let me see. My slide should be up and you should be able to see it now. So thanks everybody for joining the conversation today. Before I begin, I just want to say thank you for everything that you are doing for those people who are on the front lines day in and day out, managing this battle, working with this battle, providing services to our patients. Just thank you for what you're doing because it is a challenge out there in the rural environment. I love talking about revenue cycle day in and day out. So, this is my jam and I'm glad y'all joined me today. So with that, our just wanted to start out, include the same funding statement that this webinar is sponsored by HRSA as part of this federal grant, as Molly shared earlier. Now, what we're going to do today is to look at where we are headed. I really like to get everybody on the same page, looking at what is denial management, some current trends that are out there, building your denial management team. How does that look? Streamlining that process, and then some denial management best practices. As Molly shared, you can take yourself off of mute if you would like to ask any questions during the Q&A period or throughout the presentation. I'm cool with that. I do know that we are limited on time today, so I will be respectful of your time as well to make sure that we can get through all the slides as well as addressing any questions that you may have. So let's just begin. What is denial management? Just making sure that when I say that word, say that phrase, that we are both on the same page with this. So first, if you've ever been to one of my presentations, you will know that I show this slide because I really want everyone to understand that revenue cycle is more than just working denials. It starts at the beginning with those pre-claim activities, things to think about before you ever start providing that service. If you want to provide the service, the first question I'm going to ask is how are you going to get paid? What do you need to know to get paid for those services? And then all of the other activities to go into that. You set up the pricing for it, then you have your patients show up. They come to your facility. You may do scheduling pre registration, patient check in, claim submission, getting that claim to the payer, inbound processing where they send it back and they say, hey, here's what's going on with these activities. You get the cash in, or that's usually when you find out about the denials that you've received back. And it really falls in this back end where we're going to settle in today, looking at claim statuses, denial management, that appeals and resolution. So, when thinking about this, all of these items go together. They feed into the activities like month end closing, cost reporting, compliance, performance management, IT quality, and things like that. So, what is denial management? In a formal way, denial management is the process of investigating, analyzing, resolving, and preventing denied insurance claims for medical services provided by a physician or other qualified healthcare professional. Really, it's a lot of what your revenue cycle teams do day in and day out. Because if you don't receive a denial and that claim goes all the way through, you know what? You never see it. It gets registered and the payment comes in. And so when thinking about your team and the activities they perform, you know, they are working through these denials. Some common reasons for rejected or denial claims include coding errors, things that happen in your coding department, duplicate claims. You've already submitted that claim once before, they're still adjudicating it with the payer, lack of medical necessity, patient eligibility, and insufficient documentation. Some of these things, happen at the very beginning of the process. And then your employees must decide to correct the claim, appeal the claim, adjust it or write it off, or take the necessary action to keep the claims from continuing to age out. Now, what do I mean by age out? That is just how many days from the date the services were provided until that account becomes zero. That is an aging. Similar to us, we have birthdays. We hope that your claims do not have birthdays. We typically like to see those collected within 45 days. And so, really managing that process, what does it look like and how to work through it? Now, I've talked about some things already and want to just to clarify that I do see a difference between a claim rejection and a claim denial. And if you look, you can see I've got two little doors here. The first door is a claim rejected. It's like, try again, where it's not even accepted by the payer. It's rejected at the front door because it could be incorrect or missing data. So when working with your accounts and working with it, how are you handling these? When thinking about these claim rejections, your clearinghouse or claim scrubber finds no insurance subscriber listed, the number is invalid. These things are happening. And when you think about that doorway, that claim rejection, it's rejected by the payer. They don't even have it on file. And in honest ways of saying it, you have no hope of getting paid because that payer doesn't even know that they need to pay that claim because it bounced back when it hit the front door. And so, when thinking about that, though, your timely filing window is still ticking. The clock is going, it's still ticking. You need to correct the items that need to be fixed in order for it to make it in through the door of the payer system. Now, a claim denial, that's where the insurance company has received that claim. They're like, yes, we see it. We've got it here. It's on file. But they process that claim and deem it to be unpayable. Now, one of the things about this is that the claim submitted, it's hit their doors, they have it on file, and that timely filing window has now switched into an appeal window. So when looking at that, you're working these claims to get them paid, to get them resolved, only because they've issued a denial to you, you have a timely filing clock that is beginning to click. Hope that makes sense. Now let's talk about some of the most common denials that we see. So we're not talking about clearinghouse rejections or but these are the items that have made it all the way to the payer. The payer has it on file and they are sending it back to you. The first one could be a coding error. When thinking about this, incorrect diagnosis or missing modifiers. If the patient comes in and you have a code or a and the patient comes in, they've come in for an x-ray, and you don't include if it's on the right arm or the left arm, it could be that that claim gets denied because it is missing that modifier that says it is on either the right side or the left side of the body. One of the things that we've learned recently, especially with AI tools being out there, that if you have a claim that has an unspecified diagnosis code on there, that is something that's available in ICD-10 where you can have that unspecified diagnosis. But the AI tool will come in at the payer's side and they will say, not specific enough, deny the claim because we need more information for this. Or they may say it's not medically necessary. Some documentation errors where your medical records are insufficient or don't justify the treatment. Looking at why is the information, that falls sometimes under that not medically necessary error area as well. And then looking at non-coverage. Another denial type, that non-covered, meaning that the medically unnecessary or excluded procedures. Sometimes when we work denials, one of the things you will see, and it really causes some confusion for your staff, because you will have a test that is ordered by your physician, like a vitamin D test, that vitamin D lab test that many of your providers order. It may come back as medically not necessary, or it's an excluded procedure. One of the reasons why that happens is because when you look at annual wellness visit tests that are approved by CMS and Medicare, that vitamin D test, while your provider may order it, it is considered as an excluded procedure. It's not included, and it gets this denial coming back saying it's not medically necessary. Another most common denial type is a duplicate claim where it's already been submitted to the payer. So you may submit it originally, and then you're like, they don't have the claim on file. You send it to them, and you get a rejection that says, yes, we did have it on file. So this is a duplicate claim. Another common denial type is prior authorization denials, where the service was not authorized. When we talked about that chart a little bit earlier, you saw that there was an area called prior authorization. Are you capturing those? What does that look like? And then finally, I'm sorry for saying this, but another most common denial type is other, that they just put it in an other bucket for catching it. And that's a catch-all for a lot of various reasons that your team has to look at and really dig into to find out as to why this denial is taking place and what is causing it to happen. So, some of the current trends, I mentioned it a little bit ago, some of the current trends that are happening within the denials management piece. So, there was an ACA marketplace plans denied on average between 19 and 20% of all claims in 2023. So if you think of your workload, you can just, say 20% of your claims will get denied. There were some specific claims, I won't name names, although I'd like to, but some specific claims denied up to 54% of all claims that were submitted. So when you listen to your staff, the people who are working these claims, and you're like, why does this denial happen? That's because there are specific plans that are just bad actors within the organization because they are denying up to 54% of all claims that they receive. Payers are using, as I mentioned a minute ago, they're using automation and AI to preemptively reject or deny claims that may have previously been paid. What they are doing is they're looking for trends and they use that AI tool to identify the trends within the data that's being submitted. And then if it meets a certain criteria, they mark that claim as denied. Some of the most common reasons based on this ACA marketplace study, 34% of those fall into that other category. Oh no, I hate that generic name, but 34% of denials fall into an other. 18% fall into an administrative reason, that there could be something administratively related to your contract as to why the denial is coming through. 16% are those excluded services, things that are not needed. And then the following one, I'm sorry, Rhonda, 100% that no prior authorization, it upsets me as well. I sometimes when I talk about that, I'm like, oh man, if we could do something of that lack of prior authorization in getting those claims paid, they do irritate me. And 9% of all claims it lacks that prior authorization, and yet you may have done everything up until that point to get that prior authorization number, or they'll tell you it's not needed, and then they deny the claim for that very purpose. And then the final one, looking at that lack of medical necessity. I think that's the other one that irritates me as well, because a physician is performing services with the patient in front of them, and yet someone, at the insurance plan is saying, I'm sorry, that is not medically necessary. So just know, though, that when looking at these numbers, you are a rural healthcare provider, and when you look at your numbers and you work these claims, you may feel like you're the only person who's dealing with this. But I will tell you, you are not. Even those people in metropolitan and urban areas are experiencing these same challenges. So you're not alone. That's what I can say is that you can be. I work for the Fortune 1 company in revenue cycle trying to get claims paid, and they dealt with these same reasons for these claims. So when thinking about this, looking at this impact by the number, that 95% of hospitals and health systems report increases in time spent in staff time spent seeking that prior authorization approval. 95% of hospitals experience that same thing that irritates you out there, Ron, right? When looking at the cost of complying with the insurance policies, or these insurer policies, the cost of it is increasing. Prior authorization denials and 50% of initial claim denials that are appealed are ultimately overturned. Now, when thinking about that, when they say that the claim is denied, that's the one thing I want to leave with you. When they say that the claim is denied, that doesn't mean you have to just close the books and walk away, pencils down and walk away. Nope. You can fight for the hospital and the payments that you need to receive, because 62% of prior authorization denials and 50% of initial claim denials are ultimately overturned. And then, yes, the last bullet there is that 78% of hospitals and health systems report their experience with commercial insurers is getting worse. Well, 1% said that it's getting better. But I would say that overall, that 78% saying that experience is getting worse is what we are seeing out there in the industry. Have a whole lot of other facts and figures out there for you on this right hand side, just contributing to the workforce burden and just what that looks like, and the delay in those payments coming through, the impact that is occurring related to it. So we think about this, we've got the information, we've talked about denials, that it's happening everywhere. But when thinking about this, it's like, okay, I mean, that's great. But what do we need to do next? How can I build a team that can work these denials? And how should I look at it? Now, one of the things my colleague Ryan and I, we chat about this a lot about these top skills required for denials management and how to really find it. Because when looking at the denials management, your team is trying to solve a problem. So you're looking for somebody who's a problem solver. They want to fix the situation. They have a level of curiosity. You may talk to somebody and they'll be like, well, how'd you find that? It's like, well, I just got curious and wanted to know why. And so I started digging into it a little more, or I couldn't help myself. I started digging into it. Those are the people that you really like to have on your denial management team because they're problem solving. They've got that curiosity. Sometimes they like to work Sudoku all the time because they want to get everything to fit in the right boxes. They have communication skills. It's good to be able to dig into the problem, but then to be able to come back and share with you what they found. Is there something common they see there? They have medical coding, billing, and insurance experience. Sometimes you want to take them and have them work that front end activity and bring them back to the back end so they can understand what's going on. They have a great attention to detail because in looking at this, it's not always the first answer that's the only answer. There are multiple things at play. So, really looking at the detail and getting into it. And some analytic skills. Do they take the data and look at it a different way? Are they looking at maybe if we looked, analyzed it this way as opposed to this one? So, really thinking about these skills. Who do you have working in this area? Do you have someone assigned to working the different denials? Maybe you have someone who is really more focused on wanting to talk to patients and getting involved with them and chatting with them and building that relationship. Those people may not necessarily be the ones that you want working in the denial management. They might be better suited to be on the front end, getting patient insurance information and capturing that, asking for those copays and deductibles, and shifting your team around. Really asking them, do they like to do this? Do they enjoy it? Because you do find some people who just want to sit and dig into the detail, find the problem, and fix the problem. And then I would also say, make sure that they communicate that problem to you and you listen when they're chatting with you. When looking at the goals of this team, the main goal is to get to the root cause analysis and trend identification. If you're finding that you have, you know, all of a sudden you have this payer that is missing subscriber ID, and you're like, wait, what happened here? Let's get to the reason why they're missing the subscriber ID. And it could be that, you've got someone within denials management who notices that I've got a group of claims here that have this same trend, that they're missing this information. Getting to that root cause and identifying it and then going back to where that began and making the change. So when I think about the root cause and missing subscriber ID, to go back and go, oh, you know what? Our Blue Cross Blue Shield plan, they changed their subscriber ID numbers, and instead of being 12 digits, it's now 15 digits. And so that 12 digits we were reporting in the past no longer is relevant for us, and we've got to go get that fixing that root cause, and thereby adjusting those denials and preventing them from coming forward. Really looking at payer relations and communication, denials management, your goal to have that conversation. I didn't ask the question as a polling question, but I wonder how many of you, when I ask, when do you find out that a new provider has been hired? Is it when you get the denial back from your payer that says unable to, provider not found? Because A lot of times that's what I hear is that it either catches in the clearinghouse or at the payer itself through denials of provider not found. So within denials management, can you have that circling back conversation to where you go back to payer relations to say, why do you not have this physician on file with us? He was a founding member of our practice and still practices and seeing patients, working with that payer to have those conversations. Denials management, too, you want to look at look at working with the payers to get them to process claims in bulk rather than having to regenerate all those claims and send them. Have that conversation with your payer relations team to get it set up. And that payer relations team is someone at the payer that they work with to get these claims processed for your organization. And then your final goal for denials management is it's the first line of defense in protecting your AR. They are the ones who will see that things are changing, that all of a sudden your Medicare AR is going from you've got money sitting in the 0 to 30 and the 30 to 60 bucket, and then all of a sudden it's starting to age out into that 90 bucket. And you look at it and you're like, what is going on? The reason I say that so stressfully is because Medicare typically pays you within 15 days. And so if it's aged into that 31 to 60 bucket, to have your denials management team really digging in to understand, are those claims on file? Why are they not being paid? What are the denials you're receiving back on those claims? And managing that AR and monitoring that information coming through. So, how do we streamline this? We talked about setting up this team and working with them, but how do we streamline the information that's there? First thing I would say, you need to have a KPI dashboard in place. And then with that KPI dashboard, start looking at your denials, tracking what matters for your denials. Looking at the different types, you can see that we have two charts here, and the one on the bottom actually tracks it by denial category. Looking at the areas that are there and then saying within your team, what is an area of concern for us? So if you look at this one, November's red all the way around. And so it's like, okay, we need to focus on one of these areas. We can't focus on all of them at once, but then working through that to identify those areas of concern. This is what we're going to focus on, and then from focusing on those, then correcting it and remediating it. So you can see that for this practice, they looked at it and they fixed the coding, the medical necessity, and the non-covered, really put a project in place to fix it. Yes, some others went out of whack for a month, but coming back to look at it. And then by February, those first three items were trending positively and seeing improvements within that. And looking at it well as well to think about the different pieces within your denials management puzzle. Do you have standardized procedures in place, especially on the front end when capturing that information initially? Is that information captured consistently for all of your areas? But then when looking at your denials, digging in and understanding the data. Do you know what is causing the AR to go up? Are you seeing trends in it? Could it be that other category you have a bad actor on one of your payers who has started dumping everything into the other bucket? Do you need to pull some of those codes out, and instead of it being falling into other, it needs to fall into its own denial category? What does that look like? Do you understand the data that you have? Review and trend your information so that you can have an immediate response to the items that are going on. When looking at the slide before, you could see that we had graph lines on the right-hand side of our denial puzzle, looking at it to say, oh, we've got a problem. And I'm going to skip back to real quickly, like looking at the prior authorization. When it went red in December, all of a sudden they hopped in to find out what was going on to fix it in January and February so that by March it had then trended green. But we could also look at the line over here on the right-hand side that trended that to say we've got to make a response to this today. We can't wait. We must get on that. But then also, do you have flexibility and adaptability within your organization? Could it be that you just need to establish a way of looking at the data differently instead of always looking at it by type of denial? Go back and look at it by day. We do live in an electronic society and we think that everything passes through automatically. But could it be you have a single day's worth of claims that are not being paid, or a single day's worth of claims that have a denial, the same denial on it, because there was some information that glitched and didn't make it all the way to the payer? Looking at that, adapting to different ways of looking at your data and being flexible about it. Going back to that curiosity, really going in and saying, what's going on here? And what if I look at it this way instead of looking at it the way we've always looked at it? Really look at building a relationship with your payers. You know, if you are reviewing the remittance advices and understanding the way that the information is coming through and the way you may see your denials happening, then you can have those conversations with your provider representatives. It may be that sometimes you need to escalate it into a project and give them a group of claims that just says, these 300 claims, you have short paid me $100. We want our money. We need to have a conversation about this. There is nothing wrong with doing that, and I highly encourage you to group claims together and share the data with your payer to let them know what you are seeing. Do you have regular conversation with those payer representatives? I will say, oh, I know. I'm going to say it. That you get a good one, and the good one's so good that all of a sudden you no longer have the good one anymore for that payer representatives, the one who is working with you and fixing your problems and adjusting it. That does happen. I know some of you too, you get a good one. It's like, I'm not sharing their name with anyone because they're my go-to person. They help me out. And if I overload them, then, they may not work with me anymore. I get that too because a lot of times we're really looking for those good payer representatives. But then also, when thinking about if you don't have a payer representative, if there's not one available, can you access the payer policy and policy changes and understand how your contract states that you should be paid? If you are a critical access hospital, if you are a rural health clinic, you have a rate letter that comes from Medicare to say this is how you should be paid. Taking that rate letter and going back to your payers and working with them to say, here is our information. We should be paid this. That doesn't, when they're short paying you, that doesn't really fall in denials, but it's the same theory, making sure that you are receiving reimbursement for the services that you have provided at the rate you should be paid. And then really know what payers cause the most headaches and have the greatest ROI when working on those claims, and which contracts that may or may not be as valuable. Sometimes you look at it and you're like, this payer causes us nothing but a headache. We don't need to accept them anymore because it costs us $300,000 to work $10 worth of claims. That's a little exaggeration there, but sometimes you've just got to go, maybe we need to cut ties with this payer because they just if there is no ROI for us working these claims. So when thinking about it, having that relationship with the payer, going to the payer and saying, you may have it covered members in our community. However, you do not pay us for these services. For the 100 claims that we send to you, you deny 90% of them. It's not worth it to us. You need, and that could be too why some payers are getting out of your market because they are looking at it just saying there is no ROI for the work that we are doing. If they can look at the ROI, so can you, having that data available to you. And then really, we're thinking about denials management. It does require continuous improvement because you want to make sure that when looking at the circle, having the information being analyzed, gathered and analyzed, you identify your top priorities, you correct the top issues and the root causes, you educate your staff and review the progress, and then you go back to the data again and find the next one out there. Really setting short term goals for correcting these major issues. I will tell you that denials management, it it is a situation of whack-a-mole sometimes, or you're knocking one down and you're like another one pops up. And you're thinking, can I just get to the point at which I have no more denials? Unfortunately, that's not the case. So really continuously training your staff and educating them on changes to payer policies, behaviors, how to do that, fostering this culture of continuous improvement where you celebrate the wins of fixing a denial, but then celebrating the fact that you get to go find another one. And we're going to work on that together as a team. Having that continuous improvement mindset really then changes the attitude and changes the theme of your department from being, oh, I've got to work another denial. Yes, denials are coming. We looked at it a minute ago. 68% of all denials, all claims for prior authorization are getting denied. It's out there. It is happening. And so if you have a culture of continuous improvement where we're going to get better, celebrate when you get better with one payer, going on to the next one, and then working that as a team really does change it from a drudgery into something that they can work together and see successes on. Some best practices related to denial management. What we are seeing out there in the marketplace. The first thing I would say is you want to develop a multidisciplinary approach to working your denials. Think about it. If you get a denial that comes through and it's not medically necessary, I'm sorry, I'm an accountant by trade. I went to school for accounting and I got into revenue cycle. I can't tell you if it's medically necessary or not, but I know that I'm going to fight that denial. So, how am I going to fight that denial? I'm going to go get a clinician and bring the clinician into the conversation to say, why are they telling me this is not medically necessary? That clinician's going to be like, it is. I saw the patient. I worked with them. And then together, me, the accountant, and the clinician can get together and say, how can we fight this? Calling the payer to say, get their clinical person and our clinical person to talk to each other and have that conversation. That multidisciplinary approach will most likely lead to a successful resolution because a clinician explains to the other clinician why that was necessary and perhaps getting the payer to change their policies or to understand maybe we need to change a clinician's behavior of leaving that vitamin D test on every standing order to not necessarily be on there, but only bringing that in when medically necessary. Thinking about involving patient access. We've been talking about denials, things that happened at the back end of our revenue cycle process, but everything really begins at the front with registration, eligibility, patient collections. I used to back in the day that you could just wait and collect it on the end, and we didn't receive denials. We just received copays and deductibles going after it. That's not what's happening now. So really looking at how can those people who are in patient access assist you in getting capturing those those prior authorization, that insurance verification, all of that information to make it all the way through. That's another part of the multidisciplinary approach involving finance, the impact of bad debts, write offs, AR changes. They're looking at it from a financial perspective versus the accounts receivable team who's looking at it from an aging and what's going on with the specific payers. By bringing your finance partners into the discussion and asking them to share with you what they are seeing in the numbers, may give you an ability, the insight into, oh, we haven't looked at it that way. Let's go dig into this and hold this payer accountable. I will say your finance partners too may be the ones who have executed the payer agreements and having because they saw the financial benefit of having this contract, but then going back to them and saying, what we thought was going to be all great over here, they're denying 90% of our claims over here. Maybe we need to rethink this. They call the people and have the conversation. And then finally, looking at involving your IT department. Could it be that in the example where the Blue Cross plan changed their subscriber ID number and from 12 characters to 15 characters, maybe it wasn't Blue, but another plan, that you involve IT to catch that information up front? Are there updates, some workflow decisions that if you had this group of all of you getting together in a monthly meeting to look at the AR and together develop a plan for addressing it, then looking at bringing your denials and reducing those and working together to successfully overcome those challenges that you face. When working your denials, if there's no formal denial report exists, clean up the rejections and adjustment codes and use the data to track the denials. I will tell you, I've looked at creating a denial report, and there's not a pretty way to do it out there. They really are just numbers on an Excel spreadsheet. So if you have someone who really loves Excel, partnering with them to pull that data and creating that report, maybe pulling a report out of your system. Does your clearinghouse have summary reports that they can give to you about denials that come back? Can you create some clearinghouse edits to put into place to prevent the claims from going out because you've noticed a denial that if it's this diagnosis code and this procedure, the claim always gets denied? Then going back and looking at that. When working the denials, always focus on fixing the trends. I mentioned a minute ago that there are payers who are using AI. The reason they are using AI and what they are doing is they're noting the trends within the data and they are rejecting it and denying it back to you. So when looking at your denials, trend at the denials that you're receiving by payer, by provider, what does that look like? And then focus on fixing those that you see trending in the data. Some adjustment codes when posting the payments with the denials coming back. Are they specific to the payer? Can you put them in a specific category? The distribution of the adjustment codes compared to the adjustment codes available, does that seem necessary? Sometimes you may have 3,000 adjustment codes out there and you really need to cut it back by 30. Looking at that, do you have denials that fall into work queues that no one's ever looking at? Denials that you have an outside billing company and it's like, oh, they work denials for us. But sometimes they've flipped it back over to you and it's sitting in a work queue that you're not aware of. And then really, making sure that you are using these codes consistent across all revenue cycle departments. Is your outside billing company or is your payment post, all of your payment posters or um, the automatic processes that you have set up in place, do they use these adjustment codes consistently? And if so, or if not, what are you doing to address it to make sure that when we say this is a denial for unauthorized service, that it means the same for all payers? Really looking at denials management, getting to the root of the problem. Some of the ways, some of the frequent some of the common frequent denial reasons that we see coming through. What I've given you here are a list of those denials on the left-hand side. So the insurance denied, can't ID patient, preventative service denied for frequency, no prior authorization denied, obtained, or medical necessity. Some of the questions to get to the root of the problem, we talked about getting to the root cause and fixing it, are over here on the right-hand side. So if it says insurance denied, you can't ID the patient. Some of the questions to ask are, does the facility have eligibility software? Is the insurance updated at every visit? And what documentation is used to ID the patient? Asking those questions. So if when you are looking at your denials, you see that you have a can't ID patient as the denial reason coming back, going within your facility to ask these questions. When looking at preventative services denied for frequency, is the ordering provider tracking the frequency? Have they provided that service with it, twice within a 12-month period, and yet it's only allowed once? Does the denial team inform the provider of those frequency issues? Thinking back to that cross functional team, having that clinician, sometimes it's easier for a clinician to talk to a clinician. And then has the payer policy changed on the frequency? That happens too. No prior auth, looking at is the test required to be authorized before service? Does the facility have a prior auth team in place and process? And does the scheduling date allow for time to obtain that prior authorization? And then the last one with medical necessity, are the payer policies known and housed somewhere for viewing? Is that a commonplace? Does the denial team inform the ordering and servicing departments of this medical necessity requirement? And are HIM and coding performing the proper review? Is the appropriate information attached to one another? What does that look like? Another way to think about working these denied insurance claims is monitoring your appeals and resolution. Have you exhausted the timely filing? Do you have exhausted your appeals? Was it denied appropriately? If so, what lessons can be learned? Are you tracking it? Incomplete appeals. Did the follow-up staff request the proper information from HIM? Did it get requested but no one followed up to make sure you got it to send it off to the payer? What does that piece look like? And how are you working the appeals and resolutions within these claims? Is it falling between the cracks within your department? Do you need to look at it and address it? And then looking at the denial and rejections in different ways. I mentioned it to you before, like where we're tracking it by category, but maybe you need to shift it around and look at, is it a problem by payer? Could it be that it's a problem by a provider? So, is it a United Healthcare problem or is it a Dr. Jones problem? Or could it be it's not a United Healthcare problem, it's not a Dr. Jones problem, but it's actually a radiology issue that you need to pay attention to? Could it be that there is a group of CPT codes? I will tell you that vitamin D, the way we found out about it is because every single CPT code, and I'm not going to quote it because I didn't look it up before, but I know there's some of you yelling at me going, it's this, Amy, that CPT code. Is it always denied? What does that look like throughout your AR? Could it be it's an aging bucket? You might have missed claims within the aging bucket or looking at it based on dollar value. I always joke about how it could be a group of claims that are $12.52 that are all denying. Why are those claims for $12.52 denying? What is the reason related to it? And then getting to the root cause of that. Um, that's a good way to really look at those pockets of opportunity to be like, hey, I have it written on here. It's like, does the data pass the smell test? Does it feel right? If you have that person who's very curious, likes to work the denials, getting into the information, That's the person who's probably going to look at you and go, this doesn't feel right, or it just doesn't smell right. Um, Listen to them because if they're in that and they feel it, it's worth a look to go dig into what they may be seeing because there could be that opportunity for you to capture. So, when looking at this, a call to action, just in summary, track the denials in the detail, in detail, document your processes because it could be that bad inputs could impact the output. Posting, write-offs, appeal process, how does that work within your organization and really tracking that? Using your data to help identify the best steps to take for a high ROI on your time and which claims to appeal. Do you have a billing company that they're paid by the hour, so they just touch every claim, it doesn't matter? Or do you have an organization that they're paid by the dollar value and they go through and actually work those higher dollar ones that have a higher likelihood of getting paid? Informing other departments of their impact on revenue cycle and denial management, and partner to be most effective. Looking at that cross-functional team. We were looking at it by it was a service line. And that service line may have been at the time a radiology department. Do you have someone within radiology that you are working with to address those challenges? And then commit to continually learning and adapting to the payer tactics and policies. Unfortunately, what worked yesterday may not work tomorrow. We are in a battle with them. It's harsh to say, but they are um, working to pay the claims to the way they say they see they need to be paid, and we're looking to receive reimbursement for the services that we've provided. And so when looking at their tactics and policy, really making sure that you're learning and adapting to the changes that they may be putting in place and new AI tools that they may be utilizing every day. So with that, that gets me to the end. Here is my contact information, and I think we've got a few minutes left, Molly, if we want to open it up for Q&A to see if anybody has any questions. I didn't see them come through the chat.
Thank you so much, Amy. Yeah, come off mute, enter questions in the chat. I'll be monitoring that. Um, we did get one comment from Rhonda. This prior auth upsets me. Hang on.
Yep.
I'm getting a denial. No prior auth was needed, but they had to prove it.
Yeah, and it is a challenge out there to prove it, and then that's sort of too when I come in and just say, here's my clinician. Can I have a clinician talk to a clinician? What do we need to do to get this done? But then also other successful tactics that I've seen out there related to prior authorization are around just having a manual in place that says for these services being provided, here, this is what's required for the prior authorization. And there is nothing to say that you cannot get the patient involved in obtaining the prior authorization, letting the patient know that we're working on their behalf to get this prior authorization from their insurance company for the services being provided. Any other questions? Any comments?
I'm not seeing anything else in the chat, so it's open to anyone that has comments or questions.
Amy, would you mind if I ask a quick question?
Go right ahead, Mike.
Uh, just in relation to, the AI battle that is now working against a lot of rural health teams because the payers are really using the system. Have you seen many AI systems that have worked within the denials management space to kind of, I don't even know if they'd be automated enough to push back the denials, but mostly just identification of why it was denied in the first place to kind of give some clarity and to help, alleviate the exploring process, I would say.
Yeah, Mike, that brings up a good point. I have not personally seen it. I would say that doesn't mean that it doesn't exist. But in my personal view, Depending on the volume, I think a good analytics tool is an analytics tool versus an AI tool out there, although that may seem very antiquated. So the answer is I haven't seen it. I get what you were saying, but as a starting point, it's more just looking at your denied claims in bulk and making sure that you've captured the information. Does that make sense?
Yeah, I think
Yeah,
so. So it's not necessarily, that it isn't out there. It's just that it may not be something that's so empowering that it can't just do the job for you.
right.
It's going to be, yeah, there's going to be follow through no matter what. Yeah,
The
thanks.
the thing that is challenging out there that I see on it is really working with your eh, that's sort of along that line of an AI or automating things is in that payment posting area. That when your payment post that when your claims come in and the denials come in, that they may have shifted a denial category on you and making sure that that doesn't fall into a contractual adjustment. That, all of a sudden a CO 45 falls in. It may have been a denial in the past, but a change in a system puts it in a contractual. That's one of those areas to really leverage that automated posting to make sure that you're getting those CARC and RARC codes appropriately identified.
Gotcha. Okay. Thanks, Amy.
You're welcome. Thanks for asking. Anyone else?
Well, I certainly learned a lot. I'm not an expert in this area at all, but um, as someone from the outside, this was very, very helpful. Thank you.
I will say, if you are working through these denials and something comes up and you just need somebody to bounce some ideas off of, understand what's going on out there, feel free to reach out to me. I'm happy to chat with you, look at what you're seeing, especially being in a rural environment and a rural community. It feels very lonely, and I would even say in a big community, revenue cycle does feel very lonely because we speak this different language. So if something comes up and you want to bounce it by somebody, do reach out. Don't I say it to everybody, and my family's very grateful when you call me and talk to me about it, so I'm not talking to them about it. But reach out and we'll do it. One of the things that was noticed, I would say, that we saw commonly around denials was around that method two billing. And if you were billing for method two billed claims in that area, and then in the RHC side, the vaccines and things like that, those are some common themes that we are seeing related to those denied claims, and happy to just work through that with you and share, some best practices and solutions regarding those specific areas or those two specific issues that are out there.
Well, if there are no other questions, thank you all for joining. A few things before you leave. You will get the recording, a copy of the slides, which will have Amy's contact information. There will also be an option to receive one ACHE credit. So keep an eye out for our follow-up email. There will be a survey that you can complete to get your credit. If there are any other questions, reach out to our team or Amy. But again, thanks all for being on and keep an eye out for other webinars in the future.
Thank you.
Thank
Thanks,
you.
everyone.